A 30-year-old man from a rural area presents to the dermatology clinic with multiple hypopigmented patches on his skin, particularly on his arms and face. These patches are numb to touch. On examination, there is loss of eyebrows and thickening of peripheral nerves. Skin biopsy is performed and acid-fast bacilli are identified within the macrophages. The patient reports a history of similar symptoms in his community. Which stage of Mycobacterium leprae infection is most consistent with this clinical presentation? Is it tuberculoid? Is it lepromatous? Is it borderline? Or is it indeterminate? So there is no doubt that this is leprosy. That is already given in the question. What are the pointers that will tell you what type of leprosy is it? So starting from the beginning, he has got multiple hypopigmented patches. Patches are numb to touch, which means that the nerve involvement is there. There is loss of eyebrows, thickening of peripheral nerves. Again, there is nerve involvement. There's eyebrow alopecia. On skin biopsy, acid-fast bacilli are identified. You're able to see the acid-fast bacilli. And there is a history of similar illness. So when there are multiple lesions, when there is a nerve involvement that is seen, and you're able to see the acid-fast bacilli, you are seeing these eyebrow alopecia, all that points to lepromatous leprosy. I hope there is no confusion. If there is confusion, we will clear it with the discussion. Okay, no worries. So why is it lepromatous? I would say diffuse nature of the lesions, multiple nature of the lesions, the presence of nerve involvement, the presence of AFB, all these will point towards lepromatous. So let's have a look at this table here. Okay. So there is both lepromatous and tuberculoid. Lepromatous is multibacillary. The bacteriological index is 4 to 6 plus, and there are symmetrical lesions with irregular margins. So you have symmetrical lesions with irregular margins. More than six or even more than 6 will be the number of lesions that you get to see. And these lesions could be either nodules or papules or plaques. Okay, all these could be seen in this. And the patient will also have leonine facies and eyebrow alopecia. So these are some of the findings. So symmetrical lesions, irregular margins, nodules, papules, plaque-like lesions which are known as xanthoma, with leonine facies and eyebrow alopecia that will also be seen. Okay, and 6 or more skin lesions will be there. Nerve involvement is usually a late feature, and hyperesthesia is a late sign. 2 or more nerves will be involved. So that is also seen, and the smear will be positive. Whereas if it's tuberculoid, it's paucibacillary. So 0 to 1 would be the bacteriological index. And you'll find asymmetrical lesions will be there, and they will have sharply demarcated borders. So you will have these hypopigmented annular macules will be seen with well demarcated borders and central tendency for central clearings. That's how it will appear. And the skin lesions will be less than 6 usually. Nerve involvement occurs early. Ulnar and postauricular nerves are the ones that are commonly involved, and nerve abscesses are usually seen with borderline tuberculoid. And nerve involvement is usually one. Only one nerve will be involved, and this will be smear negative. Okay, no worries. We'll discuss this again. Lepromatous leprosy. From the name itself, you should try to remember that it is really leprosy. Okay, it's like really, really very severe. So that means it is multibacillary. The bacteriological index is 4 to 6 plus, and you've got these symmetrical lesions with irregular margins, which could be either nodules. You have to imagine the what can I say, the deformities that you get to see. So it can be nodules, or it can be papules or plaques with eyebrow alopecia and leonine facies, and more than 6 lesions will be there. But nerve involvement as such occurs late, and 2 nerves at least, okay, will be 2 or even more than that, and smear will be positive. So it's like really leprosy. Then coming to the tuberculoid type of leprosy, it's paucibacillary. The smear is negative. Bacteriological index is 0 to 1. This is the one that you get to see in your clinics sometimes. That is, there will be more of a hypopigmented annular macules and that will have elevated margins and a tendency for central clearing. Less than 6 in number, that is 5 or below, that will be the ones that are normally seen. And nerve involvement also, only one nerve will be involved. And ulnar or postauricular nerves are the ones that are commonly involved, and abscesses could also be there. Now, what about the treatment of paucibacillary versus multibacillary? So, what all do you call paucibacillary? Tuberculoid, borderline tuberculoid, and indeterminate. These three come under paucibacillary, whereas lepromatous and borderline, these three come under multibacillary. Okay, so tuberculoid, borderline tuberculoid, and indeterminate are pauci. And for paucibacillary, you can give dapsone and rifampicin. Rifampicin 600 mg once a month supervised, and dapsone 100 mg daily self-administered. And the duration of treatment is about 6 months, and follow-up has to be done annually for up to 2 years. Okay. Whereas if it's multibacillary, there is dapsone and rifampicin, same as in pauci, along with clofazimine 300 mg once a month supervised and 50 mg daily self-administered. And the follow-up has to be done for 1 year or until it becomes smear negative. And the duration is for 1 year or until it becomes smear negative, and the follow-up has to be done for or annually up to 5 years. So multibacillary is a much bigger problem. You've got lepromatous, and borderline coming in multibacillary. Okay. So when you say borderline means they've got features of both, it's a little bit hard to categorize into which one, but it's less severe. And when you say indeterminate, it's a little earlier on in the lesion. There's not that much of a nerve involvement, and as such, there will be fewer lesions. Now, if you also look at the classification, Ridley Joplin, we all know, lepromatous, borderline, borderline tuberculoid and tuberculoid leprosy. Then there is also the Indian classification and the Madrid classification. So in Madrid and in Indian, you've got lepromatous, borderline, tuberculoid, and indeterminate. So these, that is lepromatous, borderline, tuberculoid, and indeterminate, is seen in both Indian as well as in Madrid. Only thing is there is a pure neurotic type also, which is unique to the Indian classification. Okay. So these three are multibacillary, whereas these two are paucibacillary together with indeterminate. Okay. The next question, a 50-year-old man presents to the emergency department with a sudden onset of profuse watery diarrhea, vomiting, and severe dehydration. He reports that the symptoms began a few hours after consuming raw oysters at a coastal restaurant. On examination, the patient appears severely dehydrated with sunken eyes, dry mucous membranes, and a weak, rapid pulse. The stool sample is described as rice water in appearance. A stool culture is performed, and the image below shows the bacterial growth on thiosulfate citrate bile salt sucrose agar. You have the image here. Which of the following organisms is responsible for the condition of the patient? Is it Vibrio parahemolyticus, Vibrio cholerae, E. coli, or Salmonella enterica? So the reason why they've given this question and prolonged it so much and given the options of two Vibrios is to create confusion, because here the patient gives you a couple of points which can be confusing. One is he's got profuse watery diarrhea. Okay, that much is clear. He gives a history of consuming raw oysters, and he's definitely dehydrated, weak rapid pulse. He's got rice water stools, and it is growing on TCBS. Okay, so among these options, Salmonella enterica, no, it does not produce symptoms like this at all. No rice water stool for that. When you see the word rice water stool itself, you know that the answer is Vibrio cholerae. What is it that confuses it with Vibrio parahemolyticus in this question? One is that Vibrio cholerae, how you can differentiate is Vibrio cholerae produces watery diarrhea. Like we mentioned in the previous question, parahemolyticus produces dysentery. Oysters, shellfish consumption and all that can be overlapping between cholerae and parahemolyticus. Even parahemolyticus also definitely associated with consumption of oysters. Then TCBS, what is the color of the colony that you get to see here? See, it's yellow colored colony. Yellow colored colony due to sucrose fermentation is seen with Vibrio cholerae, whereas green colored colonies because of not fermenting sucrose is seen with Vibrio parahemolyticus. So here the answer is Vibrio cholerae. Okay. Then let's just discuss a little bit about the lab diagnosis of cholera. So about the lab diagnosis, freshly collected stool sample is always preferred to rectal swabs. Swabs are usually preferred for carriers. Then you've got transport media, you've got enrichment media, and you've got selective media. Transport media, Venkatraman Ramakrishnan medium, Carey Blair medium, alkaline salt transport medium, and autoclaved seawater. Then direct microscopy, you can see these gram-negative, slightly curved rods that can be seen. They are comma-shaped and they're called fish in stream appearance with darting or shooting star motility, as you call them, comma-shaped rods. And culture at 37 degrees Celsius, they are strongly aerobic and they produce a non-specific hemolysis, which is known as hemodigestion on blood agar. So sometimes you can be given this image, okay, and you can be asked, what is this phenomenon? This particular patient is having such and such symptoms. This is hemodigestion, which is classically seen in Vibrio cholerae. Then enrichment and selective. So enrichment, you've got alkaline peptone water and Mansour's peptone water. So alkaline and Mansour's peptone water, these are the classical enrichment broths. And then selective, you've got TCBS, thiosulfate citrate, bile salt, sucrose agar, sucrose fermentation, yellow colonies. Then you've got alkaline bile salt agar and you've got Mansour's agar as well. I don't try to simply say the Mansour's etc names. It's not important. Just remember Mansour's agar, okay, and Mansour's peptone water. Bas. Then what are the biochemical reactions you get to see? It is oxidase positive. See this violet color that you get to see that usually develops within 10 seconds. Okay, that shows the presence of the enzyme cytochrome oxidase. This is oxidase. This is oxidase positive. Then comes the nitrate and indole, that is nitroso-indole positive. That is what is responsible for the cholera red reaction. So cholera red reaction is nitroso-indole positivity that is seen in Vibrio cholerae. Then string test with 0.5% sodium deoxycholate. Okay, you get a long string-like structure here. This positive string test is also a characteristic feature of Vibrio cholerae. Then parahemolyticus causes gastroenteritis, it more of dysentery, green colored colonies. E. coli will not grow in TCBS, Salmonella enterica will not grow in TCBS, and none of these will produce rice water stools. Will it produce? No. Okay. Absolutely no rice water stools. Next question. A 28-year-old man presents to the clinic with a painless ulcer on his genitalia that appeared about 2 weeks ago. He mentioned that he had unprotected sexual intercourse with a new partner about 3 weeks ago. On examination, the ulcer is firm with well-defined borders and a clean base. The patient has no other significant symptoms. A dark field microscopic image from a swab taken from the ulcer is shown below. And you get to see something there that looks like a spring, isn't it? Which of the following is a most likely mode of transmission of the organism identified in the image? Is it blood transfusion, sexual contact, vertical transmission from mother to child, or contaminated water? Okay, so this is a man who's had an unprotected sexual intercourse. And he's coming with a painless ulcer that has got a clean base and well-defined borders, no other symptoms, okay? And on dark field microscopy, you are able to see something that is spirally coiled. And what is the most likely? So what are we discussing here? This is a case of primary syphilis. Yes. Any doubts as to why it is primary syphilis? Because you've got an ulcer on the genitalia. That's a painless ulcer with a clean base, firm. All those are classical findings together with a history of unprotected sexual intercourse and a dark field microscopy showing a spirally coiled organism, everything pointing towards Treponema pallidum, which causes syphilis. Now, the question here is, what is the most likely mode of transmission of syphilis? Is it blood transfusion, sexual contact, or vertical? Anyway, it's not through contaminated water, that we all know. All these three options can transmit syphilis, but the most common mode and the mode pertinent to this question is through sexual contact. Okay. So it's primarily something that is transmitted through sexual contact, okay, which includes direct contact with a syphilitic sore by anal, oral, or vaginal sex, whichever way that it happens. And vertical transmission can occur, but not here. And blood transfusion used to be a very important method, but not now with the onset of good screening processes. Now that we have discussed syphilis, let's talk a little bit about, what all you get. This is a direct microscopy. Yes, secretions or swabs from the lesions can be used for direct microscopy, and you get these slender, spirally coiled, organisms which are flexible, and you can also see the motility, which is classically corkscrew motility. Why does it have that motility? Because it's got something called as the endoflagella. So endoflagella are responsible for the corkscrew motility. And direct fluorescent antibody staining, that is very 100% sensitive, something that is done with the fresh sample. So direct fluorescent antibody staining for Treponema pallidum. Then to increase the thickness, you can also do a silver impregnation, and Fontana and Levaditis staining can be done. So that way also you can see it. Then there are other tests like serological tests. So serological tests could be either non-treponemal or treponemal test. So non-treponemal test is when you're using a non-specific cardiolipin antigen to detect the reagent antibody. So it's detecting a reagent antibody, which is again non-specific, and is using a cardiolipin antigen. And it's primarily used to look for response to treatment, and there is a possibility of a biological false positives. So VDRL and RPR are the most common non-treponemal tests that I use. Both are slight flocculation tests, but VDRL is microscopic, whereas RPR is macroscopic, and CSF can be processed on VDRL but not on RPR. So RPR is not for CSF. Okay. Then there are others also. You leave that. Just remember, non-treponemal uses reagent antibodies. It's non-specific. It is used to check for response to treatment. There's a possibility of BFPs, and VDRL and RPR are prototypes. Treponemal test uses specific treponemal antigen to identify the specific treponemal antibody. There are different tests like TPI, TPHA, TPPA, and FTA-ABS, of which it is the most sensitive and specific test, for all stages of syphilis is FTA-ABS. And for congenital syphilis also you can use, for CSF sample also you can use, and it's also the first serological test to become positive. So that's one very, very important aspect about FTA-ABS. Okay, so directly also you can do direct microscopy, direct fluorescent antibody staining, Fontana's and Levaditis, okay, for tissue and all that stuff. Then you can also do the treponemal and non-treponemal tests. And what are each? What are the advantages? What are the problems?